Good afternoon, everyone. In the child psychiatry, we don't want to go into that detail because we want to be protective, because ECT, even in the adolescent psychiatry, it is quite stressful to use it, but when we look at the literature, there is more information than we think. And this is the summary of 4 presentations in terms of child psychiatry, because I will be talking about the history, indications, side effects, assessment, ethics, conclusions, because this is important. Then how is the evaluation algorithm going to be? In 19 and whether the children should be given ECT or not. There are 40 case group between the ages of 5 to 19. It's an important series. They showed that ECT is quite safe, and afterwards there was an increase in using ECT in the mania and schizophrenia, and towards 60s there was a decrease in ECT. And if you think about the 60s, they might be against that.
There are also some associated problems.
Yeah.
After 80s, ECT comes back, and every now and then there are reported cases of use on children. Year 2000 onwards, there's a guideline published for adolescent and child use. American Association of Child Psychiatry publishes practice parameters, and that's what I used for my presentation. Neurogenesis at the end is important because children are living things, and there might be many problems neurobiologically, and for use on adolescents there are conflicting ideas, so further research is needed. We have question marks about adult psychiatry, and it's of course more problematic for use on children. Indications are mood disorders, schizophrenia and other psychotic disorders, catatonia, autism, intellectual deficiency and severe self-injury in cases of severe retardation. And if there are many neuropsychiatric symptoms, there might be other cases as well. I didn't include them here. American Society of Child Psychiatry has 3 criteria. The first one is diagnosis. It has to be a severe, persistent, major depression or mania with or without psychotic features, schizoaffective disorder, or less often schizophrenia. Number 2, catatonia and neuroleptic malignant syndrome. 2, severity of the symptoms. Severe, persistent, and significantly disabling, so damaging the quality of life of the patient. And life-threatening symptoms such as refusal to eat or drink, severe suicidality, uncontrollable mania, and florid psychosis. And of course, in child psychiatry, if we're talking about treatment resistance. That's a very complicated subject because there are some also ideas about inefficacy of these treatments or medications on children. Therefore, this is a critical subject. Another issue is the response to treatment. Lack of treatment response, failure to respond to at least 2 adequate trials of appropriate psychopharmacological agents or other appropriate treatment modalities. Both duration and dose determine the adequacy of medication trials. It may be necessary to conduct these trials in a hospital setting. ECT may be considered earlier in cases in which adequate medication trials are not possible. Let me give you some examples in terms of mood disorders. The first one is the Ryan-Walters study or review of 60 studies from 1997. 154 patients, 7 to 18-year-old with mixed diagnoses. 63% of the cases, 63% remission rate for unipolar depression, 80% for mania. When we look at the care reports, we see higher rates like 100% remission in 10 patients with depression, 75% remission in 4 patients with bipolar. Besides clinical improvement, shorter hospital stay durations compared with controls in bipolar disorder, particularly for adolescents. Few other examples. Case reports, 15 and 17-year-old females suffering from MD with psychotic features resistant to pharmacotherapy, 6-year-old girl with MD with catatonic features and food refusal, 50% weight loss, clinical improvement after the 3rd session and complete resolution of catatonic features by the end of the ECT, depressive episode and or suicidal behavior. This is a review of electroconvulsive therapy practice from a tertiary child and adolescent psychiatry center. It's a 10-year study. It was effective in 80% of the cases. In 80% of the cases, there was no significant side effects. When we look at the details, schizophrenia, bipolar, depression, temporary psychotic situations. Interesting, of 22 cases, 12 with catatonia, and there were some other symptoms as well. ECT is difficult to apply as the modality. If you can't differentiate the symptoms well enough, you might have problems. Agitation, aggression need to be looked into. In most cases, the duration is 6 months or longer, and case severity is severe or highly severe. Why were these patients chosen? Because there were no efficient psychopharmacological agents. Unilateral, lateral, frontal applications are administered. Or 70% received optimal results. In terms of side effects, 15 no, 4 headache, and in 1 case lengthened episode. After the EEG, 3 cases have also suffered from lengthened episodes. So EEG, ECT is recommended for adolescents and children. So the efficacy is quite high. In 46% of the cases, post-ECT relapse is observed. And 4 of these cases, compliance were related to various stresses. This is a 20-year practice review of electroconvulsive therapy for adolescents for psychotic disorders and catatonic cases. Most responded positively. In this article, the focus is on lengthened episodes. However, it's also deemed to be an effective treatment. Schizophrenia and psychosis, improvements in symptoms in 42% of 36 adolescents diagnosed with schizophrenia. The response rate is higher in schizophrenia with an affective component. If there are effective indicators or symptoms or resistance to treatment, then ECT can be administered. If there is treatment resistance, clozapine needs to be considered. Clozapine is a good response if it's supported by ECT. It can reduce hospitalization duration. There is a lengthened episode risk. In a 2-year monitoring study, 2-year follow-up study, there is no side effects or negative side effects. This is from Delapsia. Mr. Ömer talked about this also. In one study, ECT and non-ECT antipsychotic users doesn't have much difference, so ECT doesn't have much difference in that regard. Another important issue is catatonia. Catatonia in young populations is improved with ECT. Catatonic features in mood disorders, schizophrenia, physical illness. The remission rate in catatonia was 75% in a sample of 24 patients, Ray and Walter, 1997. It has high efficacy in many case series or case reports. So what do we need to do if there's catatonia? If there is catatonia, we can use this autism algorithm for children and adolescents. Lorazepam can be administered. We can look at the efficacy. If there is no response, then ECT is proposed. If there is lack of response, then ECT can still be considered. Neuroleptic malignant syndrome, NMS. NMS is a subtype of catatonia, responded to ECT in several case reports. Self-injurious behavior. Self-injurious behaviors have been reported to significantly decrease with ECT. There were some photos I forgot to put in my presentation. Severely mentally retarded children might inflict these self-injuries. An 8-year-old boy with autism and self-injurious behaviors occurring with a frequency of 109 attempts per hour. Following a course of ECT, the frequency decreased to 19 attempts per hour, allowing him a significantly improved functionality level. This is a difficult one to read, but maybe I should say many mentally retarded autism or catatonic situations or cases can be treated with ECT to receive response. This is a similar situation. Let me just share this one. This is of 4 cases. Of the 4 cases, pre-ECT and post-ECT self-inflicted injuries comparison is provided. Now we'll look at the side effects. The effects are similar actually, like prolonged seizures, tardive seizures, long-term cognitive impairment, transient headache, occasional transient delirium, agitation, hypomanic symptoms. With regards to ECT, we need to look whether there is any negative side effects due to anesthesia. no such effects are reported. Prolonged seizure is important to consider. Cognitive amnesia is important. Hypomania can be experienced. But compared to the adults, you have only 1 minute. Contraindications, no absolute contraindications in adult patients. The available literature demonstrates similar directions. Relative contraindication in adolescents may be considered tumors of the central nervous system associated with elevated cerebrospinal fluid is observed. How do we administer this? Of course, we need to use the 3 criteria to assess the patient. Now we need to get consent from the patient. If we can do that, then we can do the necessary workup and a neuropsychometric evaluation after the sessions and the treatment. We can do a neuropsychometric evaluation to compare the two. If there is no consent from the patient, then a judiciary process can be initiated. I'll have to skip the ethics part. It's quite conflicting. In terms of the conclusions, we can say that ECT is very effective treatment modality. It's not only, it should not be considered as an alternative option in terms of the side effects. It's not worse than drugs. With ethical consideration, candidates can be considered for a good clinical practice. Okay, thank you very much.